Good afternoon, everybody, and welcome to the Telehealth Learning Collaborative. This is our May edition, hosted by the North Country Telehealth Partnership. My name is Nancy Del Mastro, Telehealth Project Manager at Adirondack Health Institute. And I'm excited to kick off the meeting this afternoon with our featured presentation, which will be Reducing Barriers to Oral Health Care, Asynchronous Teledentistry, and we'll be hearing from Dr. Nicholas Gardner from Community Health Center of the North Country. Without further ado, we'll turn it over to Dr. Gardner to begin the presentation. Thank you so much.
Thanks, Nancy. Good afternoon, everyone. I'm Nick Gardner. I'm a general dentist, North Country native. I grew up in Rossi, went to school in Hammond, left to get educated and moved back in 2005. I'm a general dentist with a private practice in Gardner, and I also have been working off and on with the Community Health Center of the North Country since 2005. I'm currently in the role as the dental director with the health center. The topic today is going to be our oral health crisis in St. Lawrence County. The reality in St. Lawrence County is that we have a relatively large number of people that are very geographically separated with a climate that is not necessarily conducive to easy travel, especially, let's say, November to April. You can go ahead and bump ahead 2 slides if you would, Ray. So the research that Ray's done for us shows that in St. Lawrence County, there's about 2,800 people per dental provider. If we then sort of bore down into that information, we see that there are about one dentist for every 7,000 folks who receive Medicaid. And I think that's a product of the dental community being able to accommodate for the fee disparities that exist in participation with Medicaid. That the end result of that is access to care is severely limited and creates some long wait times and obstacles in getting folks in on a timely basis. We, having experienced the COVID crisis of the last 3 years, that hit us particularly hard in the dental department at the Community Health Center. I was not working with the health center prior to the pandemic. When we experienced COVID, the health center lost the 2 full-time dentists that were providing care in our Canton facility. That coincided with the opening of our Ogdensburg facility. So we were experiencing a situation where we had a high demand for services and at that point essentially no bandwidth to provide those services. Having had some experience working at the health center previously, and this community being something that's very dear to me, in particular the developmentally disabled population, I reached out to the senior leadership at the agency to talk about some way that I could help. And I expected that to be a one afternoon a week kind of doing something small. It blossomed into something much bigger. I guess I had an itch that I needed to scratch that was a lot more significant than I realized in terms of serving this community. And as the dental director, I'm now in the Canton facility on Mondays seeing patients directly, and we have a full-time dentist in our Ogdensburg facility. We were fortunate enough to find someone who was working on a per diem basis in the beginning and found that she wanted to become a full-time provider for our agency. We got very lucky in having Dr. Frazier join us. We have two, uh, in the past, have had two full-time hygienists at both locations. We currently have one hygienist at both locations. And that speaks also to the difficulties that we have in recruiting to this area. While the slide says the closest hygiene program is 50 plus miles away, the reality is that the closest hygiene programs are in Albany, Rochester, and Binghamton. So it's well beyond that 50-mile radius. And dental schools right now, our options are down in New York City, Buffalo, and Boston. So recruiting has been a real issue, which all leads into this idea of asynchronous teledentistry. When I have in the past talked to folks about doing dentistry in a telehealth model, uh, it really kind of surprises them that there's an possibility, that's even a possibility, that there's even any room in the dental world to do this. I think we found well, maybe not a novel approach. I think there are other folks who are doing this. We found an approach that's worked really well for us and has been, I think, created a real advantage for our patients and our agency in opening greater access. So what we do, I'm gonna have you skip ahead to the asynchronous slide. What we're doing now is allowing our hygiene team to continue to operate on a daily basis without a dentist on site. And that's afforded the opportunity for preventative care to continue and for some limited emergent care to happen that wouldn't otherwise happen. Basic premise is that the hygiene provider does exactly what they would do under normal circumstances with the dentist on site. They evaluate the patient, screen the patient, go through a thorough medical history review, and then provide their preventative care, which will include radiographs when appropriate and some intraoral photographs. We have a designated series of photographs that we've standardized for the team. And that information, along with a clinical note of the hygienist impression, is forwarded through our electronic medical record to currently me, but we've also recently recruited an additional provider to perform some of these teledental services, and she's located hundreds of miles away, which is really going to be kind of cool to see how that works. Once the information is forwarded on to me, I have a queue within the medical record software that alerts me to when I have exams that need to be completed. I review the information and clinical impressions from the hygiene provider, review the images, and then come up with a diagnosis and a care plan, forward that information back to our hygiene provider, who then has contact with the patient to work on a next step. Sometimes that next step is simply a return for preventative care in a period of time. Sometimes that is treatment planned with an appointment made for execution of that treatment in the future. And sometimes the problems are significant enough that the patient is scheduled for a review of findings appointment with me, and we have a discussion about what their current reality is, what their needs may be, and how we can plan to address their needs. The program started in September of 2020. We went in pretty slow, just kind of getting our bearings on how this was going to work. By the year 2022, we were up and running and really had a good system in place and performed almost 1,000 asynchronous exams, and we're on track to exceed that in 2023 based on our first quarter numbers. It's really, I think, opened up a lot of opportunities for us to treat people in a more timely way. And in particular, for the preventative care, it allows a nice continuation of the care that maybe wouldn't be possible if we were limiting appointments to only when there was a doctor on site. I think that sums up what I had to say. I'm certainly open to any questions. And Ray, please, if there's anything that I failed to mention that you think is important, please add to the conversation.
Thank you so much, Dr. Gardner. And yes, Ray, please feel free to add anything else that you would like to talk about on the topic. And for all of our attendees, feel free to add into the chat or the Q&A section boxes in WebEx any questions or comments that you'd like to share.
I don't think I necessarily have much to add from this end, Dr. Gardner. I think you did a great job speaking about the dental piece. I guess the only thing I could say is that, to put it in perspective from a numbers standpoint, we've been doing about 1,000, maybe a little bit more than 1,000 virtual visits per quarter in 2022, and that did carry over into 2023. And you see where the share, the percentage falls, in the dental discipline. And honestly, the majority otherwise is behavioral health, which I think all of us, certainly witnessed and experienced, during COVID, but will continue to play an important role moving forward.
Thanks, Ray. We do have a couple of questions in the chat. So the first one is, are you aware of anyone else doing teledentistry in this area? And are there services similar to yours?
I'm not aware that anyone else is doing this in the North Country or in the Adirondack region. But my lack of awareness certainly doesn't indicate that there's not someone doing it. But yeah, not that I know of.
Then thank you. The second question is, what codes are you billing for services? D9995, D9996. Are the dentists located in New York State?
So great questions. The codes that we're billing for a typical appointment would be the 120 periodic exam code. All the codes associated with the hygiene visit. So the 1110 or 1120, depending upon the age of the patient. The appropriate radiograph codes. So 4-bite wings would be a 274. We sometimes still bill the behavior management code if it's an IDD patient. And I believe the 9996 is the asynchronous teledentistry code, and that's the code that we are using. So if I'm correct on my numbers and I'm correct on the appropriate title, then the 9996 is what we're using for the asynchronous code. And the second part of that question was the location of the dentists. Right now, I'm the only one who's performing these asynchronous exams, and I am squarely situated in New York State. The other dentist who is going to be providing these exams in the near future is also in the state.
Thank you. Another question. How are you tracking how many patients get served through asynchronous teledentistry? This sounds like a very promising method for bridging that availability gap.
So to the best of my knowledge, and Ray, definitely keep your ears tuned to this. Um, we're keeping track of the number of patients served just by the number of times we're using that asynchronous code. I don't believe that we're just talking about asynchronous encounters. So, we may have two encounters with the same patient in a year's time. Maybe conceivably more than that, if we have a patient who has some sort of an urgent care need, but we've also seen them for a couple of periodic exams, regular preventative care appointments, we would bill out that code each time. So I believe we're tracking it just based on the submission of that code.
Yeah, that's exactly true from my understanding of it. And then it's just dumped off onto, an executive dashboard that I've put together that I use, to track our patients, whether that be new patients, teledental patients, whatever I might be looking into, at any particular moment.
Thank you so much. That's all I see in the chat right now. But again, attendees, if there are any other questions, feel free to pop them into the chat and I'll be monitoring it. But again, thank you so much, Dr. Gardner and Ray, for joining us this afternoon. Again, like the comment mentioned, this is such a promising method to bridge that availability gap and to get our community members the care that they need. So again, one more question in the chat. Do you use place of service code 02 when you're billing?
I have absolutely no idea. I'm not even familiar with what that means. So I can't speak to that.
Yeah, I can't either. I could certainly, reach out to our billing department and get information back to you, Nancy, that you could then, push out to the group. But yeah, I'm not aware of the POS02 either.
Thank you. Yeah, that's something that we can follow up with Louise and get back to you with the notes.
Nancy, that previous comment about opening up, capacity, that made me think of one other thing of value to share with the group. So we've had this program in place for 2.5 years or so, and I've seen a lot of patients. The feedback that I'm getting from patients and team has been positive in terms of acceptance by the patient. We're not hearing, well, I want to see the dentist, why can't they be here? This is frustrating me that I'm not actually seeing them. Those sorts of complaints have not been expressed. And we've seen a fair bit of positive response in terms of, even though the dentist wasn't here, I'm really glad you were able to see me. This is good. And it does certainly open up availability and offer different capacity for me to be able to do things that only I can do and that I could only do when I'm on site. That shifting of resources so that I'm doing some of these things that I can do off-site at off hours of the day, I think that leads to that increase in capacity as well. And there's a lot of value in that.
Thank you. That's great to hear that the feedback has been positive. Well, I don't see any other questions in the chat, but I will continue to monitor that. And then if there are any other follow-ups, I'd be happy to, email those over to you both. And actually, of course, every time I say this and sort of transition, another question pops in, which is great. So thank you all for asking these awesome questions. We have one more. It's, will the provider location be impacted by the end of the public health emergency?
I can't say for sure that it will not. However, in dentistry, the practice laws allow for hygiene providers in an Article 28 facility to practice with a little different freedom than in a private practice. So in a private practice, as I read the laws, the dentist is supposed to be on site in the building. For an Article 28 facility, that's not true. The dentist does not have to be directly on site to supervise at the time of service. So the hygiene providers can still do all the things that they've always done. I think the only thing that would be impacted by the end of the public health emergency would be whether or not we can continue to bill as we have been for the exam and asynchronous teledentistry component, those two codes. But there are places, especially out west. I know Colorado is one place where teledentistry has been happening for a while. You know, there'll be a private practice with two locations, and one of those locations is remote in a mountain town, and they'll have one or two teammates that are in that place, and they've been doing something like this for a number of years. So it's something that has proven to work, and I don't think it's going to. I don't think the end of the PHE is going to negatively impact our ability to continue to bill in the way we have been billing.
Yeah, at this point, there's certainly no impact at all in the Medicare reimbursement, and from a Medicaid standpoint in New York State, as long as one of the two, meaning the patient or the provider, are on site, we get to bill our full rate as a federally qualified health center. And obviously, in this case, one of the two is certainly always going to be, on premises.
Thank you both for those responses. And again, I'll be monitoring the chat, but at this point, we will transition into our state and federal policy updates. And again, if there are any questions for Dr. Gardner or Ray, I'll compile those and we can include responses with the notes that will be shared later this week. So again, thank you so much to Ray and Dr. Gardner for joining us this afternoon. It was really such an awesome presentation, another unique way that telehealth can assist in reaching communities in ways to meet them where they're at. So thank you again. And for our attendees again, feel free to keep popping questions in if you have any for them. So like mentioned, I will be moving into our state agency telehealth updates. Well, I'll just quickly let everyone know that there are no additional updates from the Office of Mental Health. I have shared the updated telemental health guidance a few times since our last session in March, but I will include the links to those in the notes as well. And there are some really great pre-recorded webinars from CTAC and MCTAC that have some overviews of the impact of the public health emergency on telehealth that will be included in the notes as well. So with that, I will invite Kate Bliss from the New York State Department of Health to update everyone on any telehealth guidance from the Department of Health.
Hi, good afternoon, everyone. The Department of Health had put out our post-PHE telehealth guidance back in March, and it described several policy updates, and I think I may have spoken about it on this call. But since we put out that telehealth guidance, we've received several questions over the last couple of months. So early last week, we made a couple of clarifications to that guidance document. I'll put the link to the guidance document in the chat so people can see it, but we've updated any of the clarifications that we made to the guidance, we highlighted so it's easy to see what changed. There are three major changes, or three sort of categories of changes that we made to this guidance. The first is that we're now saying that providers who typically bill a place of service 11, meaning like a provider's office, a private practice, they should continue billing place of service 11 rather than starting to use place of service 2 or 10 to indicate that the visit was done via telehealth. And the reason behind that clarification is that place of service 11 actually pays at a higher non-facility rate, while place of service 2 and 10 pay at a lower facility rate. So we want to make sure that those place of service 11 providers continue to receive the same reimbursement they would have received had the person been in the office. So that clarification just tells those provider types, keep using place of service 11 and use telehealth modifiers on your claims and encounters to let us know that this was done via telehealth. The next clarification that we made was related to the managed care plans use of telehealth modifiers. So there was language in the original Medicaid update specifying that the managed care plans could use their own billing guidance separate from what we're outlining here in this guidance. But we've edited that to make it clear that the managed care plans do have to use the telehealth modifiers because we're relying on those modifiers to be able to track telehealth utilization. And then the third clarification relates to, there's a grid in the Medicaid update in a fee-for-service billing for telehealth by site and location section that tells providers based on the facility or clinic type and whether the provider is on site, the Medicaid member is on site, or when neither patient nor provider are on site, what the payment looks like and what the reimbursement rules are during COVID compared to after the COVID PHE. So the edit that we made in this section is really just to pull apart Article 28 outpatient departments from Article 28 diagnostic and treatment centers. The clarification here is that in Article 28 hospital outpatient departments, there is a professional component that physicians typically bill and, they have been billing in hospital outpatient departments, but it's not typical for a physician to bill a professional component outside of what the clinic is paid in a diagnostic and treatment center. So we pulled those apart so that it made a little more sense why we're saying to build a professional component as it relates to hospital outpatient departments, and then clarified that for both hospital outpatient departments and Article 28 diagnostic and treatment centers, when there is no patient on site and the provider is also not on site when the telehealth occurs, there is no way for the clinic to bill Medicaid for that visit because of federal regulations that require on-site presence at the clinic. So a professional component is allowable in that situation, but clinic billing is not. So we just pulled those apart to make that a little bit more clear in the guidance. Other than that, we've added a couple more links and just clarified wording in a couple of places, but those are the meat of the three major updates.
Thank you so much, Kate. And Louise had a question in the chat asking for clarification on which telehealth modifiers are required for DOH. And I believe there is a table in the guidance document that does explain all of the telehealth modifiers. And Kate, you could correct me if I'm wrong on that.
Nope, that's correct. There's a table that has all of the different modifiers in there with the description. Yep.
Wonderful. Thank you so much, Kate. If there are any other questions, feel free to place those in the chat or send them via email, and I'll be sure to either route or answer those. So as mentioned, I'll be providing the OMH guidance documents and some links to some pre-recorded webinars on OMH guidance as well with the notes. So now I'll move to OASAS. I don't have any updates on my end, but Kelly Grace is on the line if there are any updates from OASIS to share.
No updates at the moment. We're still in the final stages of finalizing our revised telehealth standards. We have a draft up on our OASIS website, but the standards as a final document still are not complete, but we're getting there.
Wonderful. Thank you so much, Kelly. And now we'll move to any updates from CMS and the Medicare side. We have Aideen on the line if you want to unmute and share anything.
Hi, everyone. I'm Edin Zefren from CMS. The only update that I think might be of interest to this group would be we have put in a fact sheet about the telehealth and how it will change after the public health emergency ended on May 11. A few things that I would mention from that is this: as far as Medicare, the telehealth flexibilities that were available during the public health emergency was extended until December 31st, 2024. And those flexibilities include that people with Medicare can access telehealth services in any geographic area in the United States. So not just in rural areas, no matter where they live, they can access telehealth services. The second thing was people with Medicare can also stay in their homes for telehealth services, and Medicare will pay for that, so they don't have to travel to a healthcare facility. And also, one flexibility was telehealth visits can be delivered via audio only, so it doesn't have to be a video call. As far as the Medicare Advantage plans, as usual, it will vary depending on which plan you have and what they have. So, of course, we encourage the plans to provide as many benefits as possible, but that's pretty much all we can do, encouraging them. So depending on your plan, you should contact your plan and find out what flexibilities they are offering or not. And some plans can even decide to extend those flexibilities even after December 31st, 2024. As far as the Medicaid and the SHIP program, again, that will depend on the states, because obviously Medicaid is managed by the state. So each state will have their own flexibilities. And I think we just heard from our colleague in the New York State Department of Health, who told us about New York specifically. And lastly, as far as private health insurance, it will also vary depending on your health insurance. You should always ask what your plans cover and don't cover, because some of them could decide to have copay, co-insurance, and the likes. If they wish to, so it's always good to speak to your own plan and find out what they offer and they don't offer. But as far as Medicare beneficiaries are concerned, they can telehealth from anywhere in the United States. They can telehealth from their home, and it can be via audio only. The other thing that I would mention to this group was that there was a study done by the Journal of American Medical Association, and they discovered that during the pandemic, the increased use of telehealth for those who suffer from opioid use disorder, that there's been a reduced risk of overdose. So I thought that was interesting. So if anyone is interested to see that article published by Jama, I can always send it to Nancy and she can share it with the group. As far as CMS is concerned, as you know, the PHE ended on May 11. We are still working on some documents to answer specific questions we've received during proposed rules and comments people have made. But in general, as far as our Medicare beneficiaries are concerned, there's not much difference. And until December 31st, 2024, when there will be a reevaluation because some of them will expire. At that time, of course, decisions will be made. But for now, it's as if nothing has changed for them as far as COVID vaccine, COVID tests, telehealth, and so on. And that's pretty much for me. That's it for me. Thank you, Nancy.
Thank you so much. That was super helpful. And yeah, we would love to be able to share the journal article that you had mentioned. So if you could email that over to me, I will be sure to include that in the notes for reference for our attendees. Thank you.
Thank
you. We do have a question actually that says CMS added 3 codes to the May 9th telehealth list, 98966 to 98968. And it looks like they're questioning if they're no longer under communication-based technology. Adine, I don't know if you can answer that, but Louise, that's something I can certainly follow up and clarify with you.
Let me quickly read the question. I don't have the answer at the top of my head, but I will copy that and I can send the answer to Nancy and she can share it with the
That sounds great. Thank you. Wonderful. And yeah, so of course the public health emergency did end on May 11th. We've shared quite a few different documents that came from CMS, from our partners at the Telehealth Resource Centers, the Center for Connected Health Policy, all in preparation for that date. And since May 11th, there have been a few more resources that have been published to help telehealth providers ensure that they're in compliance with the new regulations and whatnot. So I'm going to compile a list of all of the resources that I've seen come through, and I will include those with the notes just for your reference. I'm sure most of you have seen many of these documents, but I'm going to compile them into one document with all of the links. Because I know there just have been so many different guidance documents that have, so having them in one place may be helpful. So again, I'll get that with the notes for everyone. And again, so those are all of our updates in the notes document. There are going to be a few other links included, which include some different articles, some different resources on all things telehealth. The DEA has extended the telemedicine flexibilities for prescriptions of controlled substances, medications. So that's something that I have some resources and guidance on that I'll be sharing with the notes. I have a new OIG toolkit on analyzing telehealth claims to assess program integrity risk. And there's a new remote patient monitoring vendor selection toolkit from the California Telehealth Resource Center. So a few resources that you may be interested in, and I'll make sure those are all included, as well as some upcoming telehealth events, some webinars that are coming up. So I'll make sure those are all noted in my notes email as well as in the document. The final update that I did want to share with everyone is, and you might have seen it via email, but the North Country Leadership Summit save the date has been released. We will be hosting our annual conference in person for 2023, which is really exciting. We've been virtual since 2020. We used to be called the North Country Telehealth Conference, previously in person. We have collaborated with the Adirondack Health Institute's Leadership Summit, which is a population health-based conference that's also hosted each fall. And we will be hosting our North Country Leadership Summit on September 27th and 28th in Lake George, New York, at the Courtyard by Marriott. And this week, hopefully, we'll be releasing our conference website with the call for presenter document with sponsorship opportunities. We'll be soliciting some applications for Telehealth Innovator Award that we'll provide to partners throughout the region that have done exemplary work in telehealth for our communities. So again, we've been working on all of our preliminary documents and getting our website up, and hopefully by the end of this week, I'll be able to share all of that with you. Again, we'll have our call for presenters open, and please, if you're interested in speaking or have partners that you'd like to see and hear speak at the conference, feel free to, send the application to them or submit applications. We're really excited to be back in person this year. And, just get a chance to really network and meet after a few years of being remote. So that was my final update. I'm going to do one more scan in the chat. I don't see anything else, but again, feel free to follow up via email. I'll have the slide deck from Dr. Gardner. I'll have the recording available and all of the resources that have been mentioned today. And again, we thank you for joining us, and our next Telehealth Learning Collaborative will be hosted on July 17th from 2 to 3 p.m. Thank you, everyone, and have a great rest of your day.
Thanks again, Nancy. Appreciate it.
Thank you.
Thanks, Nancy. I
Tammy,
appreciated the
the
opportunity.
conference will be fully in person this year, but we are dabbling with some opportunities to potentially record sessions, but fully in person this year. Thank you.